Good morning. I'd like to call this oversight roundtable of the Committee on Health to order. Today is Thursday, December 12th, 2024. The time is 9:35 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. We are in room 500 of the John A. Wilson Building, and this is a hybrid hearing with witnesses testifying. We have one witness who's testifying virtually, and then everyone else is in person. Today, we'll be discussing the planned closure of the United Medical Center and the forthcoming opening of Cedar Hill Regional Medical Center in Ward 8. This roundtable provides an opportunity for us to examine the progress and challenges associated with the transition, ensuring that both facilities meet the objectives and that the community healthcare needs are being prioritized during this significant shift. UMC's closure is a significant milestone for the facility that has served Ward 8 for a very long time, as well as the surrounding areas. UMC plans to close at the same time that Cedar Hill opens, and we want to make sure that that transition is as smooth as possible, with UMC patients being discharged or transferred when appropriate. As UMC has progressively shut down services over the last 6 months, we are also want to ensure that UMC patients have the continuity of care with other health facilities in the district. Cedar Hill's opening is also a significant milestone for the Ward 8 community, as the new hospital will bring new capacity and healthcare services to Ward 8 and the surrounding areas. The district government has invested over $400 million into the new hospital, and we want to ensure that the capacity of the hospital will meet demand and that the hospital is fully staffed and ready to serve patients on day one, as well as ensuring that the hospital is very well integrated into the environment of health providers already serving residents east of the Anacostia River. We are joined today by an invited group of witnesses from several health providers serving Ward 8 residents. We are also joined by the hospital leadership from both UMC as well as Cedar Hill, and by the Deputy Mayor for Health and Human Services, Wayne Turnage. I don't see any of my colleagues who have joined, but should any of them join us, we'll certainly recognize them. I just want to go over some of the ground rules for today. So all public witnesses will have 5 minutes to speak, and we'll provide you just with a gentle reminder when all of your time has ended. It's not that we don't want to hear from you, but we want to hear from everyone in a timely fashion. And then we'll conclude with, we're calling it government witness testimony, but you're not really government witnesses, but it will be the hospital and executive leadership for both UMC and Cedar Hill. Okay, and with that, we will get started. So I have 4 seats in front of me. Okay, and Kelly McShane is virtual. So actually, I get to call up everybody at the same time. So Kelly McShane, who's the president and CEO of Community of Hope, Dr. Jessica Boyd, who's the president and CEO of Unity Healthcare, Nasima Shafi, who is the CEO of Whitman Walker, Jaron Hill, who's the president of the Ward 8 Health Council, and Ruth is not here, but Patricia Quinn is going to be testifying in her stead. So if you guys can come on up. Okay. All right. Kelly has not joined us yet. Oh, she is? Oh, there she is. Okay, great. Wonderful. All right, Kelly, when you're ready.
Great. Good morning, Chairperson Henderson. I am Kelly Sweeney McShane, President and CEO at Community of Hope. Thank you for the opportunity to testify today and to testify virtually. I very much appreciate that. Community of Hope is a federally qualified health center and a provider of services for families experiencing and individuals experiencing homelessness. And we are on track to serve about 1,700 households in our housing programs this year, as well as to serve about 16,000 patients in our health center. And that includes about half of our patients who live in wards 7 and 8. I'm here today on behalf of Community of Hope to provide the perspective of FQHC on the opening of Cedar Hill Regional Medical Center and its potential for positive impact on the health of the district's residents, specifically those in Ward 7 and 8. I have served as a member of the Community Advisory Committee and enjoyed the opportunity to do a tour a few weeks ago of Cedar Hill. I'm excited about the hospital's upcoming opening in the spring and the opportunity to partner in providing healthcare services. As the hospital gears up to open in the spring, we have many questions about what services will be offered and when. As the plan is more fully developed, we recommend that Cedar Hill leadership create a robust communication plan for both providers and for the community. As trusted primary care providers, we expect that patients will be asking for information from us, and the more knowledgeable our providers and staff are, the easier it will be to share information and encourage use of the hospital services. Some of the information we are particularly interested in includes ways to partner on discharge planning for those with inpatient stays. We would like to partner to create direct lines of communication with our clinicians and staff to ensure continuity of care for patients. We'd also like to learn more about the types of specialty care and the phasing in of services, and want to ensure that systems are in place to get reports back in a timely manner. Information on the types of diagnostic imaging that will be offered on site, as well as on what behavioral health services will be provided and the referral process. Community of Hope is particularly interested in learning more and partnering around maternal and child health programs. We have developed a comprehensive model, and a picture of which is included in my written testimony, that is seeing great outcomes for patients. Community of Hope's team of midwives, family medicine providers, doulas, care coordinators, and many other staff provided comprehensive perinatal care to 903 patients in 2023, including 700 new prenatal patients. And our midwives supported 300 births in 2023. We are pleased to share that the percentage of our newborns with low birth weights dropped from 11 to 9% in 23, and the preterm birth rate for our patients dropped from 11 to 10%. And we have some comparables for the Ward 8 in the district in my written testimony. We are also seeing postpartum return rates within 84 days of birth at 83%. And that's in comparison to the national average of 64.7% for Medicaid beneficiaries. We believe that these improved outcomes are a result of the trusting relationship patients have developed with midwives and the integration of both clinical care and non-clinical supports, all of which will be needed for Cedar Hill Regional Medical Center to play a role in addressing disparities in maternal health outcomes in Wards 7 and 8. Hence, we are eager to learn more about what services will be provided at Cedar Hill with regards to labor and delivery. We are curious as to who will be providing OB services, if there will be a maternal fetal medicine specialist available for referral, and if care coordination services will be included. Finally, as an organization that opened a new health center in Ward 8 just over 10 years ago, we have learned the importance of building trust with community residents and the power of word of mouth. Simply building a beautiful new building is not enough. Ads at bus stops and on the radio are not enough. Providing high quality, respectful care on a consistent basis is the key to long-term success. It will also be important to build trust with the existing primary care provider base, including at FQHCs, to ensure a steady stream of referrals. At Community of Hope, we are eager to support the new hospital success and look forward to future partnership with Cedar Hill. Thank you for the opportunity to provide testimony, and I'm available to answer any questions.
Thank you. Dr. Boyd.
Good morning, Chairperson Henderson. My name is Dr. Jessica Henderson Boyd, and I'm the President and CEO of Unity Healthcare. And thank you for hosting today's Public Oversight Roundtable. I'd like to begin my testimony by extending a message of gratitude to the many people who brought this historic moment to fruition. I want to especially thank Mayor Bowser and Councilmember Gray for years of advocacy on behalf of equitable and high-quality healthcare in Wards 7 and 8, and for making the new hospital a reality. Of significance for today's roundtable, Unity is one of the largest providers of primary and specialty care in the district, serving nearly 85,000 patients and providing over 300,000 patients visits annually. We currently operate more than 30 delivery sites across the district, including full-service community health centers in Wards 7 and 8, which serve about 35,000 residents, which would likely use the hospital. Our patients are primarily persons of color with incomes below the federal poverty level, and nearly 70% of our patients participate in the district's Medicaid and Alliance programs. For these reasons, Unity is an essential partner in the delivery of high quality, comprehensive, and culturally competent primary and specialty care in Wards 7 and 8. For decades, these neighborhoods have lacked a financially stable, integrated acute care facility and system to serve the needs of the residents. Cedar Hill Regional Medical Center, when fully launched and supported, will be an essential component in addressing the health disparities affecting the residents in these communities. The district is fortunate to have a robust, high-quality network of health providers, along with the second lowest uninsured rate in the nation. Still, there are glaring disparities in healthcare outcomes that fall overwhelmingly along racial and geographic lines. Illustrative of this point, we often talk about the difference in life expectancy between Ward 3 and 8, which is 16 years. And this is where I practice. These health disparities continue to exist, even though the district has one of the most expansive publicly funded healthcare systems in the US. Social drivers of health contribute significantly to these disparities, including the lack of accessible and affordable transportation, which is a critical component of access. And this really is especially true for our patients in Wards 7 and 8 who must travel the farthest for comprehensive, high-quality acute and specialty care. In order for the new Cedar Hill facility to have an impact on health disparities, it will require a meaningful commitment to patient-centered, integrated care on the part of all of the healthcare providers and community partners. But creating the system of care is well underway and is being led by UHS and GW University MFA leadership collaboratively. To this end, Unity is an active participant in the planning and implementation of the center, working alongside local stakeholders and community health providers to ensure that the facility will meet the needs of the community. Among other things, Unity is participating in the Cedar Hill Community Advisory Committee and the Cedar Hill Alliance for Health Equity. And since 2023, we've been meeting at least monthly with leadership from both UHS and GW to discuss care coordination and pathways for connecting to primary care services. These meetings have focused largely on creating a comprehensive healthcare ecosystem like a healthy neighborhood, where acute services at Cedar Hill are seamlessly integrated with primary and specialty providers in the community. In addition, Unity is working with UHS's new urgent care center and the new hospital to identify efficient pathways for patients to access primary care when needed, whether that be after they've received services or even when possible to divert services to a more appropriate level of care. And we've been exploring algorithms designed to guide patients without a designated medical home to primary care services equitably and in ways that make the most sense for patients. These care coordination pathways are not limited to medical care and include discussions on closing the loop on referrals for social drivers of health, and really collaborations with the many community-based organizations in the region. We've also engaged in discussions about the high priority service areas that will have an opportunity to co-locate within the community. And I've shared our referral patterns to specialists by zip code with the GW and UHS leadership to help them prioritize high need services. And this is really with the goal of ensuring that the right services are available in the right locations to patients. And we've discussed and actually toured spaces to look at co-locating services so that patients can have more high-quality services in the communities where they live. One of Unity's top priorities is maternal health care. From 2018 to 2022, we know that Black and African American mothers accounted for 84% of severe maternal deaths. As a large community obstetrics provider, it's our goal to ensure that our team and our patients can deliver their babies safely at Cedar Hill, offering them continuity of care and greater choice. And we believe that significant progress is being made in discussions on that front. While there's still work to be done, including around educational partnerships, we're engaged in productive collaborative discussions with UHS and GW leadership to ensure that Cedar Hill is fully integrated into the community's healthcare system. And from my perspective, been working closely to align our goals and unite around elimination of race-based health disparities in Ward 7 and 8. On a final note, I'd like to acknowledge the remarkable contributions of the entire professional and support staff at UMC as it prepares to close. These individuals, many who've worked at the facility for years, and some who work at Unity, have given their best to the residents of the community. So thank you for your attention to these important matters. We look forward to the continued partnership in advancing the health and well-being of our community.
Thank you. Nazim.
Good morning, Chairwoman Henderson, members of the Committee of Health, and Council staff. Thank you for the opportunity to offer testimony on behalf of Whitman Walker Health regarding the advancement of the healthcare system east of the Anacostia River, specifically regarding the closure of the United Medical Center and the opening of Cedar Hill Regional Medical Center Hospital. I'm Nasima Shafi, CEO of Whitman Walker Health. As you're well aware, Whitman Walker opened the new Max Robinson Health Center site in August of 2023 on the campus of St. Elizabeth's East, relocating and expanding on care that we have provided in Ward 8 since 1996, from Anacostia to Congress Heights. In the years leading up to opening our site, we attended more and more community meetings to try to ensure that we were listening to the community needs that were raised, as well as building community buy-in for the work we intended to deliver. We are so fortunate for any trust that community and government has placed in us and believe that trust has been well earned. In our first full year of operations, we saw 75% more people than we had seen in the previous year, from 3,600-ish people to 6,400-ish in the same period. Those people included over 2,200 Medicaid beneficiaries, 919 patients for behavioral health care services, and 624 patients for oral health care services, to highlight just a small subset. Whitman Walker Health leadership had long been looking for a site for a new location for expansion in Ward 8, and we were fortunate to find the opportunity on the St. Elizabeth's campus, with the awareness that the city had made the determination to locate the new hospital also on the campus. We were eager to build a relationship with the hospital partner to collectively advance a better healthcare system for residents of this great city, and especially those of Wards 7 and 8. Our opportunity to be part of a truly transformational healthcare ecosystem in Congress Heights is one that comes but once in our organizational history, and we are motivated by what is ahead of us for the benefit of the community. Stubborn and persistent health disparities may be addressed by this integrated system when we work together in the most collaborative ways possible. We hope to highlight a few main points in our testimony today. First, the transitions of care and services that are currently occurring at United Medical Center as it plans to wind down are a challenge for patients and providers. Second, UHS leadership has had many priorities, from securing agreements with city leadership to building the physical plant to staffing the new hospital. Now's the time, as they also ensure integrated collaboration is secured by community partners and providers, and that the resources will address the health equities in the city. And third, the GW School of Medicine, medical faculty associates, and university leadership can bring to bear a wealth of population health focus to ensure that these integrations achieved improved health outcomes and lower costs of care for the district. Regarding United Medical Center, in recent years, the majority of our patients in Ward 8 have not sought care at UMC if possible. And that's not a reflection on the human beings who are delivering the care, but as a result of some of the services being closed over periods of time. Despite it being a care delivery site rooted in the community, as services began to close, shift, or fade, many of our patients preferred to seek care elsewhere if possible. Prior to opening our new site and over the past year and a half, we've been in touch with various providers at UMC, especially those housed in the medical office building. We've been trying to reach out to them, respond to inquiries from them in order to assess whether they may want to sublease available space in the building that we occupy or co-locate services within our walls. We've done this with the intention of supporting the patients who are actively engaged in care and services and those providers who work so diligently over the years. Through no fault of any party, it just hasn't been the right fit. In recent months, we have learned of our own patient challenges regarding specialty care, specifically around access and follow-up. It's clear that as staffing winds down, gaps in care and communication are occurring. Regarding Cedar Hill Regional Medical Center, we began dialogue with UHS leadership in 2019 after execution of the leases for the spaces we now occupy in Congress Heights. Our goal was then, and remains now, to assess opportunities for integration of services where possible. We are appreciative of the massive undertaking that goes into building a new facility. We are also aware of the undertaking that is now taking place to implement a staffing plan for that hospital and medical office building. We understand the priorities ahead for the UHS team, especially in these next 3 months. Service delivery tied to the construction of the physical plant was shared with us as part of stakeholder organization groups hosted by UHS. We're also in attendance of other community-based meetings where they frequently attended to provide updates. We have been partners with providers and leaders at the GW Medical Faculty Associates since the early days of the AIDS crisis in the district. While our referral and educational relationships with the MFA teams have been relational and not through formal affiliation agreements, our collective commitments to the community have been of great value. As the responsibilities associated with the new hospital have been underway by the MFA and School of Medicine teams, we have been able to offer opportunities for engagement and coordination for the benefit of our patients and community. We aim to coordinate closely and within reason with the GW MFA teams as they staff the hospital and are enthusiastic about the role that the Center for Population Sciences and Health Equity at the School of Medicine and Health Sciences has had on our ability to potentially realize other integrations. Advancing a new healthcare delivery system is no single organization's responsibility, and we believe it must be prioritized by many organizational stakeholders. We've been in many community-related meetings where we have heard great promise of what the new hospital will deliver to residents of the city. However, the hospital leadership and MFA staff alone cannot accomplish what is needed to address systemic health disparities. Primary care and other community-based providers are essential. Patient trust and engagement has to be central to all of us. We look forward to more formal affiliation agreements between organizations like Whitman Walker Health, UHS, and the GW University parties that allow for this kind of integration that will improve healthcare outcome for the residents and reduce costs for our community. Thank you so much for this opportunity.
Thank you. Ms. Hill.
All right. I'm different from everybody up here. Let me start with that. I appreciate the opportunity, council member, to speak with you all. And let me start by saying I'm Jaren Hill Lockridge. I'm not a doctor. I'm not a chief executive, anybody or anything. I'm the chair of the Ward 8 Health Council, which is an organic group of stakeholders who are advancing the healthcare needs in the Great Ward 8. I don't have the formal written testimony because I am here volunteering, right? Told y'all I don't get paid to be the chair of the Ward 8 Health Council, so I don't have a whole staff or the things that a lot of other people have. I'm here as a community member, really excited about what Cedar Hill is gonna bring to our ward, but also wondering what happens next. With the sunsetting of UMC, our community, like y'all know what's going on, and we have a lot of questions that have not been answered. With the Ward 8 Health Council, we have a couple of priorities, and maternal health care, as you know, is very big. Big question, when can we have babies in Ward 8 again? What does it mean to bring maternal health care back east of the river? I take it real personal. I take it really personal as a mother, as a wife, as a daughter, as a person that takes care of like the regular folks, right? I don't have the healthcare teams. I don't have people who work for me. It's just us trying to figure out how to connect dots when it comes to the healthcare in our community. So we're really appreciative of like Unity, Whitman Walker, DC Primary Care Association, the folks who've been on the ground, boots on the ground, getting the work done. But we also know that there's a lot more to be done. We have questions that have not been answered. We know that this is going to be an economic driver in our community. How do we connect with those opportunities? How do we make sure that we're able to take care of ourselves in a different way? That we get the jobs, the careers. What does it mean for us for real, for the regular folks? No shade to the elected officials, the important people, but what does it mean for the moms, the daughters, the people who aren't in the healthcare industry the same way? What does our wellness mean? How do we integrate with all that everybody is bringing? And right now we haven't been able to connect those dots. We don't know. We're lost and really looking forward to what happens on the other side of this conversation and the path forward. I think I'm gonna stop there because I look forward to the conversation.
I'll have some questions. Thank you. All right, Ms. Quinn.
Good morning, Councilmember Henderson and staff. I'm Patricia Quinn, Vice President of Policy and Partnerships at the Primary Care Association. Ruth Pollard sends her apologies. DC Primary Care Association works to build a healthier DC by sustaining community health centers, transforming care delivery, and advancing racial and health equity. Our collaborators in this work include community health centers serving over 180,000 patients in every ward of the city. Thank you for the opportunity to provide information regarding our members and the opening of Cedar Hill Regional Medical Center. Health inequity in the district is profoundly racialized. The social conditions impacting health are influenced by DC's legacy of racial and economic segregation, disenfranchisement, and marginalization, and by present-day racism. First and foremost, the road to health equity in the district travels through community health centers. Our members serve district residents most impacted by inequity. 95% of our health center patients are racial or ethnic minorities. 88% have incomes below 200% of the federal poverty level, and 37% are best served in a language other than English. Cedar Hill Regional Medical Center is a vital component of the district's drive toward health equity. While the new hospital is necessary, it alone is not sufficient to create the comprehensive integrated system residents in Ward 7 and 8 deserve. A truly equitable, coordinated system requires meaningful partnership and integration with the existing primary health care and social service providers in the community. Health centers serve as the primary care medical home for over 50,000 residents east of the river. Integration of Cedar Hill's specialty and inpatient care with the community health centers that make up the backbone of primary care infrastructure is essential. We must collaborate to address the insufficient resources, poor communication, and large gaps in meeting the goals of integrated care. DCPCA and our member centers strongly recommend a formal written collaborative care agreement between health centers serving patients east of the river and Cedar Hill. Such agreements help facilitate a safe and effective transition of care, reduce the chances that patients and information fall through the cracks, and help improve the overall efficiency of patient-centered care. Key elements of a collaborative care agreement may include clear referral protocols, clear discharge protocols, defined credentialing processes for community health center providers that recognize their role in primary care and fully integrate them into the health ecosystem, opportunities for educational training partnerships at community health centers with residents and medical students, and social rounding. This type of integration plan requires extensive collaboration, communication, and allocation of resources. Care integration is key to achieving the health equity goals that led the district to invest in the new hospital. DCPCA and our member health centers welcome the dialogue begun with Cedar Hill and the George Washington University Medical Faculty Associates. We hope to share our progress towards a collaborative agreement with this committee and the rest of the council in the next 2 months ahead of the opening of Cedar Hill. In closing, we urge Cedar Hill to develop and execute a comprehensive communications plan that educates and informs health and social service providers and the community about what services, supports, and opportunities Cedar Hill expects to deliver, the role it will play in the drive for health equity, and what benchmarks it will use to track progress. Thank you.
Thank you. And thank you to all of the witnesses. Ashley, you can put me on 10 minutes just so I can keep track, but we'll see where things go. I truly appreciate all of you testifying, and we're starting this because frankly, it was in conversations with community providers that I myself sort of was like, okay, maybe we're not all moving on the same timeline and same conversation. I was meeting with a community provider in Ward 7, and I think I mentioned like, oh, well, when Cedar Hill opens in March or April, and they were like, wait, what? It's ready? And I was like, well, not fully, but haven't you all been part of these conversations leading up to? And it was a acknowledgement that that hadn't necessarily occurred. And I sent a letter to the UHS Cedar Hill GWMFA team to just basically underscore, I think perhaps what everyone would say as a district resident. We did not spend $400 million to construct a new hospital for it not to be able to provide quality care, or for the community still not to feel as though this is a place where they can receive quality care. And so what are the conversations that need to occur in the next few months so that everyone can be on the same timeline about what is happening? And I think that perhaps in my expectations of things that I would have thought would have been on paper are still concepts in conversations, and even in some of the testimonies that you all are talking about, you're talking about some of those things. Ms. Hill, I want to start with you. You mentioned in your testimony that the community still has questions that have not been answered. What are some of those questions? Because perhaps today might be an opportunity to get at least some idea of some answers, or for the leadership of these hospitals to be able to execute and provide communications on those.
Well, thank you for that. When does it open? When can we
Okay.
have a baby, right? Because
Okay.
like really recognizing the maternal health care is a big piece. And to have a baby takes 9 months to incubate, right? You can't just say, tomorrow I get to have my baby there or I don't. But what does that timeline look like? And how can we as a community make sure that we're ready and prepared for whatever that looks like?
Okay.
That's it's a huge question.
Yeah. I think that part of when does it open is kind of a moving target, but I understand in terms of wanting to like have some sort of certainty. And I would suspect the folks from UMC would also like to have that certainty, but there are lots of different pieces that have to align before we can kind of get to that part. And I get it. So let's take that for instance. I think several of you, whether it be Kelly or you, Dr. Boyd, have spoken about the maternal health piece, which I think is super critical. It's something that certainly is a priority for me, and I think perhaps people are underestimating the importance of being able to deliver not in an emergency room in Ward 8, and also knowing that. Well, I don't think Whitman Walker does OBGYN. So, okay, good. All right. I just wanted to make sure. Okay, so I'll direct the question to Unity and Community of Hope. One of the big questions has been around credentialing and whether or not, well, not whether or not, but how will community-based providers be able to have privileges at the new facility? And I think in the question of maternal health, this is kind of important because as Ms. Hill talked about, right, you don't just turn around and have a kid. And I think in some, there's a desire for a planned experience, not an emergency experience, if that makes sense, right? That, you have called ahead, hey, my contractions are 5 minutes apart, I'm coming in, as opposed to coming in through the emergency room. And I don't know to the extent of how many patients in wards, 7, 8, or in the surrounding areas are already receiving care from a physician from GWMFA. So I'm going to start with you all in terms of what have the conversations been around credentialing? And because, I printed the original agreement that was signed in 2021. And so my understanding is that, there is the exclusivity between GWMFA, but that it does not preclude community physicians from being part. But it also says that in order for that to happen, UHS has to provide has to provide prior written notice 180 days prior. So if I'm doing some math backwards, then that means that we're coming about that time where we need to be able to provide some written notice. But then it also says that the community provider has to meet the credentialing standards. Are those written? I don't know. So what have those conversations been? We'll start with you, Dr. Boyd.
Thank you, Chairwoman Henderson. That's a great question. And we've been assured that our providers will be able to go through that credentialing process. I haven't seen it written on paper, but it is very similar and I imagine will be the same as it is for the GWMFA today. And that's been the assurance that we've been given.
Okay.
I think we have been working very closely with them though on how we could develop collaborative OB practices because it takes a lot of OB providers to be able to maintain a 24/7 delivery service,
okay,
particularly in the environment of heightened malpractice and really wanting to have safe care. And so that requires a robust service. So we've been talking about what a collaborative service might look like. And it's been critical for us at Unity that our patients have that opportunity for continuity of care. Lots of women want to deliver with the provider who cared for them for 9 months.
Yeah.
And so this is a priority for us. And we've been in discussions on this for over a year, actually in collaboration with Community of Hope and Mary Center, who are the other delivering FQHCs, to understand what it would look like between us and then what would that look like in collaboration. I've been a part of the care coordination work group and recently conducted a patient journey map exercise for us to understand.
A patient
We call it a patient journey map.
journey map. Okay.
So we have a lot of the providers in the community, and we have plans to bring this out to our community advisory boards and get patient input, but understanding what are the touch points and change points and transitions for patients in obstetrics care. And it's really critical that we get information seamlessly across that continuum of care so that women can have safe and high quality births and labor and delivery and postpartum experiences. So I think we actually have work groups thinking about this, but they are not yet in paper, they are not yet in agreements, but there's progress being made.
Who are part of the work groups?
So the GWMFA, the Population Health, the Center for Population Health at GW, Whitman Walker, Unity, and UHS leaders. And PIW.
Okay, and how often do you all meet?
We meet monthly, and then we have some meetings in between to have these work groups do extra projects. So my team has also been engaged in an extra project on the discharge pathways and planning.
Okay. And are there, I'm going to get to you, Ms. McShane, but are there timelines in terms of the work group? So I have an interesting relationship with work groups and task force. Task force in particular. I'm done on moratorium on task force because I feel like we use these as an opportunity to put all these people together to just continue having circular conversations as opposed to actually producing an actionable product.
So we actually are pretty action oriented. I mean, you're taking a lot of leader time, but I would say after that OB journey map, one of the critical issues we identified was information sharing and the opportunity for CRISP to help us have a continuity care document for obstetric care. We immediately called the CRISP people and they're coming to our meeting. That's this Friday.
Great.
So I think that we've been regular in meeting. I think that there still is pace to be had. But I think we're all aware of the opening timelines. And so there's urgent pressure to do that. I was having a discussion with Kim earlier, but it's like we're taking 50 years of a lack of integration and trying to integrate. And so that is needing to be done in a stepwise fashion. And I think the work group is also trying to prioritize the information we need right away. So just like Jaren is saying that women are going to be having births there immediately. So let's take that topic on urgently. And we're still looking at chronic disease pathways and behavioral health pathways. And Nasima may speak about that. She's been doing some of the work on that side as well. But I think there is alignment that maternal health is a priority and there is urgent work being done.
Okay. Kelly?
So I would say Community of Hope has not been as involved in these conversations. Several years ago, we'd started some, but not as much recently. I mean, obviously, Unity does have more patients than we do. For Community of Hope, we have a midwifery practice, so we do not have OB. So the question for me that I'm not sure about yet is whether midwives will be credentialed. And then for us, we have deliveries both at our freestanding birth center at Washington Hospital Center. So adding another location does have significant implications and costs and other things that we would need to consider whether that's possible for us or not. I do want to go back to, it's not just the delivery of the baby in the moment of birth, but back to that relationship with the prenatal provider, back to the care coordination, the support around social determinants of health, all those different components. And so I think for me, again, we're interested and learning more and seeing how we could partner when the appropriate time comes, because I do think we provide a really great set of services.
Great. Well, thank you for that. Let me ask this. Some of you've mentioned in your testimony, you've been collaborating with UHS and GW through the Cedar Hill Alliance for Health Equity. How have those meetings been going?
I think the meetings, we've actually distributed them out to some of our staff. And so I know that they've had a couple of meetings. My team was involved in the maternal health meeting and I believe the behavioral health meeting, but I haven't heard ongoing progress about that. So I believe that they're on pause, but I haven't heard what the plans are for those meetings.
Okay. Ms. Shafi and Dr. Boyd, you both testified about specialty services and data sharing on information around like what are needed, those kinds of things. What are some of the specialty services that you've highlighted as priorities in your conversations?
We've highlighted cardiology as one for us. That seems quite important for the patients that we serve. We've been in conversation around a full host of supports for people living with cancer, for everything from diagnostic to treatment and what that might be on the campus. I think those have been some of the major priority areas that we've highlighted.
And for us, we highlighted cardiology, neurology, nephrology, and gastroenterology as key priorities. And this is really based on 5 years of experience of our referral patterns and include looking at completed referrals. So if we look across all of the systems in all of the hospitals, how far are the patients going? We also restricted it to zip codes. We looked at the patients that are in the 6 primary zip codes that will be the service area of the hospital and provided that referral. So the referrals I provided you were like the top unaddressed referrals in the area.
Okay, so, but some of the, well, not for cardiology and for cancer, but some of the other ones that you mentioned, oh, I think UMC had neurology. There were a couple of specialty lines that you mentioned that UMC didn't currently have or hasn't had.
And part of the challenge in the city during the pandemic was that certain specialty services may be more or less available with capacity. And so you can see backlogs in areas, you can see less trust that there is a provider. It's very hard, we have 200 plus providers. And so keeping all of them abreast of what specialty services are available where is challenging, which is sort of why we started the dashboard on the services. And so part of it is giving recruiting suggestions, right? Like, this is what we really need. We have this many gastroenterology referrals and they're not getting completed. People aren't able to get in. We also
Well, can I ask a follow-up to that? When you say like, they're not being completed, is it someone received a referral and perhaps the distance from the specialty is too far, or they received a referral and they're on a wait list?
It could be both. We track time to completion of referral. So we can look at those who were completed and see about how long that takes. And that tells us it gives us a high level view of how long it's taking patients to get in. Plus we get qualitative data from the patients themselves.
Okay.
And so neurology was an interesting one because there were a lot of neurology referrals, not that much neurology capacity. And we've even discussed the issues around post-stroke mobility and transportation, and that maybe that gets a little bit higher priority because it's hard for people who've had a stroke to really want to get across town to go to a specialist.
Yeah.
And so we did take some other factors into consideration in making those recommendations.
Okay. Ms. Shafi, your clinic in proximity will be the closest.
That's right.
And, how can they be a good neighbor?
We are, even a recent conversation is how we might be able to provide collaborative pharmaceutical services.
Yeah. You have a nice, beautiful pharmacy.
Thanks. To the Cedar Hill regional teams. I think the most optimistic opportunities I see include having FQHC staff physically located in the hospitals. I think it's a great opportunity for discharge-related work and coordination of care and the social drivers, all the things that we're really good at. And so that's one of the ways. We've talked even many years ago about what does it look like to share transportation, socialization events for our staff, meal sharing, things like that on the campus as we create this entire experience for the employees who are on that campus. But in particular, it's really around the coordination of care for our patients.
Yeah.
And I think the most that we can do there is how they're going to be the best neighbors.
Yeah. I was talking to someone a few months ago and they said, who the most important hires in a hospital? And they asked that question. And, I'm thinking, okay, is it some sort of particular physician, et cetera? And they're like, no, the most important hire is who is doing patient coordination and also who is greeting. And I was like, oh yeah, when you come into a hospital, depending on whatever the circumstance is, if you're there for a particular appointment, if you're there for a surgery, if you're there for whatever, how you are received has a lot to do with what you perceive to be the next steps of whatever your particular care is. And then once you are finished with your appointment or your surgery, who is calling you to check in and say, okay, so you're done, here's your post-op appointment, and we're gonna do a follow-up at Whitman Walker, and here's your appointment time. Seamless. All done.
Yeah. And our community deserves that experience.
Okay. I'm glad that crisp is coming. I think I met the representative from Chris. Yeah, a couple of weeks ago, and they were really excited about this opportunity to do some things that, what she said, that they haven't been asked to do in the past, although they've always had the capability to do. So it's like, okay, great, let's let's lean in and do something different here. Okay, is there anything I haven't asked you that you want to share? Any question you feel like I should, I obviously have a number of things here. This is your moment.
I'd like to just echo maybe what Naseema said around care coordination. And I think it's important just for people to understand, we often talk about like, where does the resource come from? So the community health centers may have some really great assets to bring. Kelly has a lot of community health workers, Naseema has community health workers, we have community health workers and care coordinators. But one of the things that we identified is when they're in the hospital, they actually have pretty good access to things and we don't know about it. And they have social work services. They can connect people to long-term care facilities, other type of facilities, and we don't have that information. So we as a city have to be thinking about how do we support each of the players with the greatest assets that they have and figure out how we can coordinate that. So when we're talking about FQHC staff being in hospitals, it's because they understand the patients, have access to our systems, but that may not be an FQHC generated resource because we don't have the funding for that. But we have to think about its importance in the entire ecosystem and continuum of care.
Okay. Ms. Quinn?
I think what we're looking for is formal commitment to this care coordination work, regular meeting for years on out, because we need to do continuous quality improvement in those practices. So some structure for how once those agreements are made, how we're going to track and know what's working, what isn't working, what needs adjustment on a very regular basis.
Okay.
I think an area we haven't talked about quite yet, and I don't think we need to belabor it, but there is significant behavioral health needs in the community, all the things. And I think one of the areas we've talked about care coordination is specific to what it will look like to step patients down out of emergency services into the community. And there are a wealth of community resources in Ward 8. I think it is a misrepresentation to say it's not well-resourced. So there are these, the family strengthening collaboratives and other organizations that do a lot of great work that can also be plugged in to provide help.
Yeah, I will mention that on the behavioral health side, we have had a number of conversations with healthcare finance, the deputy mayor, DC Health, and DBH around that because the capacities are different. So what the size of the behavioral health unit at UMC is not the size of the behavioral health unit at Cedar Hill as built out. So now we have to have a conversation as a city about what are we doing in terms of the capacity around some of these cases. And so that conversation has already happened and is ongoing in terms of how do we sort of balance out. And I think that's also something that folks, I don't know to the extent to which they acknowledge or recognize. It is not a one-for-one, right? Exactly what you get at UMC is not going to be exactly what you get at Cedar Hill, which is fine. But we just need to, I think, as you said, sort of be very aggressive in our communication around, what are the services, what's available, when can you walk in, and all of those different things. Okay, I'm trying to get oh, yes.
With that coordination, that's the question of how do we connect the dots so that regular folks can understand these are the resources and assets that we can access. That's the missing piece, right? Great assets here, great assets there, but how do we connect those dots so that we can find ways to get on either of those dots to actually have a comprehensive healthcare system that we understand how to navigate? It's great that y'all got all this money and all these resources to do all those things, but if we, the folks who need it, don't have access to the services, what are we doing? You know what I mean? Like, how do we connect to those dots?
Yeah. All right. Thank you all. Thanks so much for being here. Okay. All right. I think the kind of best way to do this might be to to split, because I have 6 and I have 4 chairs, although I think Ms. Chakuma is on the interwebs. Okay, so Dr. Payne Borden from UMC, Angel Jacobs, who's the United Medical Center Board Chair, Ms. Chakuma, who is the CFO for UMC, is online. All right, and we'll have the deputy mayor join us when he arrives. Okay, who is providing testimony amongst you three? Great. All right, Dr. Payne Borden, when you are ready.
Good morning again, Chair Henderson and staff. My name is Jacqueline Payne Borden, and I am the CEO and CNO of United Medical Center, not-for-profit hospital corporation. I'm here to give an update on our closure activities. So I'll start with how we created our draft plan. It was developed in collaboration with the executive leadership team and supported by a project manager. And it was approved by our fiscal management board in October. And we have submitted the draft plan to SHPTA and to HRLA, and we're waiting approval. Our closure is in 3 phases. We're waiting approval for the 3rd phase. Our closure is in 3 phases. The first phase, phase 1, was completed the end of August this year. It included closures of the outpatient specialty clinics and services such as GI, ortho, urology, cardiology, or outpatient lab and radiology. Our second phase, the anticipated closure, is December 20th, and this is for our primary care clinic and our GYN clinic. Our third phase, which is the second quarter of fiscal 25, however, dependent on when Cedar Hill Regional Medical Center is ready to receive patients. And that would include the closure of all our other services, and I'll just highlight that: our emergency department, all our inpatient services, which includes behavioral health or PACU, and our ancillary and support services. Throughout all 3 phases, we have been and will continue to provide support for patients. We do have a communication plan to keep relevant internal and external stakeholders informed, and I'll just highlight a few. Primarily, it would be our patients, our employees, our providers and vendors, the regulatory agencies, emergency medical services, and our community leaders. Our staff, they're very important and dedicated, and the support we're providing for them is providing regular notices and communication. We have the voluntary training program for our staff if they want to, and it's in conjunction with UHSGW. At present, we have 210 UMC employees who have registered, and at least 134 have completed at least 1 module. Other outreach activities for employees includes reaching out to other healthcare facilities and for career opportunities. And as recently as November, Cedar Hill provided a career fair on campus, as well as Bridgepoint in December had a career fair. Other support includes information regarding benefits and retirement. And we have had, for example, Mission Square and Care First to come on campus and have one-to-one meetings with staff who wanted to talk, as well as seminars, group seminars. In order to ensure a smooth transition to closure and post-closure support, we are engaging with agency partners throughout the DC government, such as the Office of Risk Management, OCTO, Office of Contracting and Procurement, and Department of General Services. And the Not-for-Profit Hospital Corporation will dissolve by September 2025. That's the end of my update. Thank you.
Thank you. Just for additional context for folks, I have been having regular meetings with Dr. Payne Borden and Ms. Jacobs and Ms. Chakuma as we have been going through this process of closure. So, I think some of the conversation for us today is around getting some of this on the record. We've had conversations, but we want to make sure that the public is informed about some of these things that are going on. I think probably the biggest, which might be of surprise to some people, maybe not, is around primary care clinics setting to close next week. Next week?
By the
Next week,
20th.
the 20th
Potential.
of,
Yes.
so just for clarification, what departments will remain open after December 20th?
What departments within the
Yes,
hospital?
besides emergency.
We'll have our med-surg telemetry. We'll have dialysis. We have our behavioral health. We have our operating department and post-anesthesia care unit. We will also have all the ancillary services such as lab, radiology, that will all still be there.
Okay, and in terms of the anticipated closure that's happening next week, how much notice did you provide patients, and how are you going to connect them with alternative points of care? Primary care is kind of important. I mean, obviously there are other
Yes.
options. Clearly,
Yes.
some of the folks who testified right before you.
So for all the clinics, including primary care and GYN, which will be anticipated closure December 20th, patients have been receiving notice at least 30 days, 30 to 60 days. Some of the patients receive face-to-face. All patients receive letters in the mail with return receipts. We have our website, which has the closure dates, which has resources as well. They click on a link and there is a resource list for specialty care, including some of our community partners here today. And as well as it's on the website, as well as in the mailers that we have been sending out to patients.
Okay. You mentioned around the closure plan being submitted to SHPTA for approval. What's the status of this approval, and are there any delays anticipated that could affect the
So
closure
far,
plan?
there are no delays. We're waiting to hear from SHPTA. We are way beyond before the 90-day notice that we should give them for the full hospital closure.
Okay.
So based on the phases, we submitted portions for those phases timely. So for phase 1, we have our full closure, and phase 2, we're still waiting. However, we can go ahead and do what we need to do in order to close.
Okay. And one of the things we talked about too is it's not just around the SHPTA closure or approval, but the equipment at UMC. Some of these units that you're already closing, whether it be neurology, et cetera, they've got some equipment there. We want to make sure that that gets properly transferred. What's the plan for that?
So I can speak to radiology regarding our MRIs. The vendor came in and did whatever shutdown they needed to do so that it remains in place in a safe posturing until the procurement for the district decides what they're going to do with it.
Oh, okay. So
It's not our equipment. We don't own. I see Lillian.
I can speak to that if you.
okay, Ms. Chakuma.
Yeah. Chair Henderson, good morning. How are you?
Good.
Of course, we have a comprehensive listing of all assets. As you know, the city gives us the money for all capital expenditure, so we don't own any of it. So what we have done is we have put all those, we have done an assessment, done an official evaluation with a reputable company that the city uses, and we have the value, and we have turned that over to the city's DGS, the people that are responsible for it. And what we're doing is each phase of our closing, we have indicated the date when they can go ahead and dispose of the asset. But what they will do is to dispose it, by sale or however, and then of course the salvage value will go to the district. So all those ones that are already closed, we have taken them off our books as we're working with the auditors. They're no longer part of our books. And then the individual that is responsible for that in the city is already making plans and to know how to dispose of them. So that's what's happening. And we are also getting together a listing for Shifter. Shifter also requested that we give them a listing of those equipment that needed approval for before we acquire them, and we are getting all those ready also to send to them. So everything will be done properly and in order, and none will be kept or given away or disposed prior to the closure of the hospital. It will go by stage. Our wound care closed, so the hyperbaric is being, considered of what needs to go. MRI closed. The MRI machines are being planned to take care of. The vehicles that we don't need, all of them are going in stages, and they will all be disposed properly by the district. But it is
Mr.
the
Kuma.
district's, yes.
Let me ask a follow-up, because I don't think I realized that DGS was a part of this. Is if you could follow up with the committee and perhaps share which division of DGS is you all are working with, or who is responsible here, or maybe Miss Jacobs has something to
Yeah, I
add.
just, excuse me, I'm
Ms.
Angel
Jacob,
Jacobs.
what's-
I'm the chair of the Fiscal Management Board. I just want to clarify, the agency actually for the disposal is the Office of Contracts and Procurement. That's where the surplus.
OG,
unit-
okay.
That's-
Okay,
yes.
okay, I was confused. I was like, why is DGS in
I'm
this?
sorry.
Okay, great,
No,
all
Yes.
it's
right.
the Office of Contracting and
I'm
Procurement
sorry,
that is
so,
responsible
yes.
for taking care of the surplus
OCP, yes,
and
I'm
making sure
sorry.
that it's appropriately disposed of.
Yes.
Okay.
Martin.
And I think, Ms. Jacobs, it would still be helpful to know which part of OCP, if you could tell us offline who that is.
Absolutely.
that you
Which
guys are
Martin,
working.
which one is Marvin's? I don't know his department, but
We'll get you the information.
Okay, great.
Mm.
Okay, so I want to ask about the staffing. You gave a little bit of an update here, and I think kind of everybody understands what the agreement is around. There is no guarantee from staff being able to shift from UMC to Cedar Hill, that there were these training modules that, you needed to complete and X, Y, or Z. 210 staff registered, only 134 have completed at least one module. Obviously, it's not your responsibility to, I don't know, encourage or require anyone to sort of move through that process. But I just want to make sure that all of the staff is aware that
Staff
this
is
is
aware.
a prerequisite.
Yes,
Okay,
they
so,
are aware, and they had a very good interaction with Cedar Hill when they came
Okay.
for the job fair. So that was very encouraging for the staff. So I applaud Cedar Hill for doing that activity now. This is crucial time for them to have done it.
oh, so they recently did a hiring
Yes,
fair?
Yes,
Okay.
November 19th or 18th.
Oh, wow, okay,
Yes,
so this
yes.
is, so now I think for the staff, they can see like, oh, this is a real thing that is
Yes.
about to happen, so let me get my act together.
Yes.
Hopefully. Okay, and so what have your conversations been in that regard with Cedar Hill around the fact that, yes, you may want to hire my staff, but I also need my emergency room department I need staff for it to sustain.
Yes, we have had good dialogue with that, and we tentatively, I know they need good people, and we have good people, and if they should show interest in any of our folks, the plan is for us to talk and see how we can make sure that UMC is not shortchanged, but also that Cedar Hill will benefit when we close.
Okay, all right. I want to talk a little bit about patient transfers. So you all, like other hospitals, might have some patients who have been with you for a while, though they might not need that level of acute care any further. Those are probably some of our hardest to place individuals because, again, they don't need the level of acute care, but there is no place for you all to safely discharge them to. What are the conversations been about those types of patients in particular?
So for those type of patients, we have been working with Deputy Mayor Health and Human Services with Mr. Ben Stutz and other groups, including Department of Behavioral Health, because we know when we have our involuntary patients, that's crucial. And so we have been working diligently every 2 weeks, and we are chipping away at our small numbers.
Okay, how many?
For example, 8, and we're down to, I believe, 4 that we still need to work on, but they're diligently helping us getting vouchers, getting home health aides. So it is working, but it is a process. So I'm glad we started early.
That's good. Okay, so we're down to 4.
We're down to 4, but that's a moving target. Because once you have an admission, things could change.
Okay.
Yeah.
But every 2 weeks having conversations and sort of doing this kind of work.
Yes.
You know, it's interesting. Some might say, or some of your colleagues from other hospitals would say, if they can do this work with you, why can't they do this with us?
Well, they're trying to help us close properly.
I understand, and that's great for you, but I think that I'm looking at Ben and the team from healthcare finance over there. I regularly hear it from some of our other hospitals, and so maybe perhaps this could be a model in terms of how to sort of triage some of these particular cases. What about behavioral health in terms of involuntary and the FD12 patients? I imagine that there needs to be some particular protocol here, not just in terms of transferring someone who's currently, well, at the time, this is hard because who knows where you'll kind of be in March and April, but transferring those who are currently existing, also informing FEMS, right, of no longer admit or transporting
patients.
patients to UMC.
So we plan on scheduling some meetings at the beginning of the year to talk about situations as such.
Okay.
But I know for sure we've talked with Cedar Hill, and we're both cognizant of the fact that for behavioral health, for example, we would need to have personnel be with the patient during the transfer. They cannot independently go in a ambulance or anything unless you have a trained person with them. So we're talking about that.
Okay. Are there any conversations around whether or not Cedar Hill can start with 0? i.e. anyone who's currently at UMC being transferred to other existing hospitals, so Cedar Hill is not starting with a patient that they didn't originally have in care at the beginning of their
Can you say that again?
admission. I'm trying to say this as delicately as possible, but I can imagine a situation. I'm trying to think about it from the perspective of me, new hospital, new doctor seeing this client for the first time. Is there any realm in which I can start from 0, meaning that a patient is not transferred from an existing hospital when it comes to behavioral health, but rather any new FD12 admissions are fresh admissions?
You mean on Cedar Hill's end?
Yes, on Cedar Hill's end. So what I'm saying is that any behavioral health patient that's still currently at UMC is transferred to another hospital, not Cedar Hill.
You're asking if we would do that?
I'm asking if any conversations have happened.
Oh, we haven't had that depth of conversation yet.
That's all I'm.
Okay, sorry.
That's all I'm asking. Okay, we looked at the website really quickly. It didn't have the list of alternative providers listed.
There was a link that you had to click on.
Okay. We'll start on that.
And I have checked it recently. So.
Okay. All right. While we're looking at that, Ms. Shakuma, let's talk a little bit about contracts. You know how the chairman feels, not me, the chair of this committee, but the chairman of the council feels about retroactive contracts. How are we doing in terms of getting caught up?
I'm sorry. Chair Henderson, can we get back to you on that since we don't have our contracting officer and our legal team here today?
Okay. So let's follow up on that front. Okay. I don't have any further questions at this time. I mean, and I'm trying to think through what I know versus what we should be talking about here. And I know that we're going to continue to have conversations ongoing as we kind of move through the process. I think probably the biggest thing for you all is just around communication, communication with your patients, communication with your staff, and then open communication with the community around, number one, the ED is open until it's not. So it's not as though you cannot receive emergency care in Ward 8 if you need it. It is, you exist, you're there. And then two, around as we're doing some of these unit closures or service line closures, just making sure that patients are connected and not just going without, whether it be in wound care or otherwise, to make sure that they're still receiving their services, because without it, they could probably develop something much more critical again.
Yes, ma'am. And if I might add, some providers are in our building and they provide specialty services as well, including LabCorp and some other cardiologists and so on. So that's reassuring for us as well as we see our numbers dwindle.
And I just wanted to add, we are fully committed to the continuity of care. Even as we close clinics, we will make sure that our patients have access to information about those providers where they can get those services.
Okay. All right. Thank you. Okay. Yes.
Just a bragging moment, our CIO Vanilla received from DC Hospital Association an award for healthcare innovation. So thank you.
Congratulations.
So we're still keeping standards.
Thank you. And that's good to hear. Congratulations. And thank you all so much.
Thank you.
Okay. We'll now talk to Dr. Anthony Coleman, who's the CEO of Cedar Hill Regional Medical Center, as well as Kimberly Russo, who is the CEO of George Washington University Hospital, but the group vice president for UHS, her area. Okay. Hang on one second. Okay, and we've also been joined by Wayne Turnage, the Deputy Mayor for Health and Human Services, as well as the Director for the Department of Healthcare Finance. Okay, I understand in terms of order, we start with Dr. Coleman. Do you have a statement, Ms. Russo, as well? Okay, and then we'll end with Deputy Mayor Turnage. Great. All right, when you're ready.
Good morning, Councilmember Henderson. My name is Dr. Anthony Coleman, and I serve as the Chief Executive Officer of Cedar Hill Regional Medical Center, GW Health. I'm here today as one of the representatives of Universal Health Services for the purpose of this hearing. Appreciate your invitation to testify today, and I welcome the opportunity to share a wide range of updates for this vital initiative. I'm honored to lead this project. Cedar Hill will be a pillar in the community we serve, beginning the first day the new hospital opens, and it'll positively impact the delivery of healthcare for years to come. Cedar Hill will be groundbreaking for all district residents as the first new hospital in DC in nearly 25 years, and it will ensure the pursuit of health equity for residents of Wards 7 and 8 through continued access to high quality care in their own neighborhoods and communities. Thank you for this opportunity to share 5 areas of focus for Cedar Hill. I'll begin with construction completion and regulatory approval, which are in concert with the district. The new facility is 85% complete, and it's on track to be delivered by the construction company in late January 2025. We're working with DOH and DOB regarding inspections in the following 5 areas: pharmacy, lab, loading dock, kitchen, and business licenses. The second area of focus is staffing the new hospital and preparing to do business with the district and its residents. We've made a lot of progress to date. Regarding staffing, 5 job fairs have been planned with 4 completed. The 5th job fair will take place this Saturday, December 14th at the Dorothy I. Height Library in Northeast. We've received a tremendous positive response to these Cedar Hill events with over 500 people attending so far. Our job fair at UMC totaled over 200 people. All the job fairs were held at locations in Ward 7 or 8. And looking forward, these efforts will be continued into 2025. One of our district partners, the Department of Employment Services, has expressed interest in coordinating a job fair in January or February of 2025. To date, we've hired 5 mid-level leaders, and we're currently hiring select frontline staff. Those frontline positions include biomed technicians, lab technicians, and supply technicians. Our plan is to have all leadership on board by early March and all frontline staff on board by mid-March. In our quarterly Ship to Report Out, we've shared that we have 17 UMC applicants and 4 offers so far. This number will increase greatly soon as we send out additional offers and post more positions, as we're filling mostly leadership roles at this time. We're also partnering with DOES to train 30 district residents in healthcare jobs of sterile processing technicians, phlebotomists, patient care techs, and pharmacy techs. Some will be starting as early as this Monday, December 16th. We continue to work with DOES to secure a first source agreement to hire DC residents for jobs at the hospital. The specifics are still being worked on. One way we're preparing to do business with the district is referring businesses that are interested in working with Cedar Hill to DSLBD for Certified Business Enterprise Certification information. Our Director of Supply Chain, who also serves as our Facility Contracting Officer, began employment on December 2nd. One of his priorities include developing a contract list for dissemination. Additionally, we have 2 signed contracts with CBE vendors. One is Curate, which is a company that catalyzes our ability to partner directly with local food and beverage businesses to feature their products throughout the hospital. The other signed contract is with Tag B Parking, a local parking and transportation company that will be operating our garage and other potential offerings such as transportation, power washing, and signage. We're also exceeding our CBE commitment with regard to construction of Cedar Hill facility. Another area we're focused on is expanding our integrated delivery system east of the river through clinically integrated networks with federally qualified health centers east of the river, many of whom you've just heard from earlier this morning. Cedar Hill is part of an integrated delivery network of care that includes the George Washington University Hospital, Cedar Hill Urgent Care, GW Health in Ward 8, the Fletcher Johnson Freestanding Emergency Department scheduled to open in 2027 in Ward 7 pending Certificate of Need approval. Additionally, Cedar Hill will also integrate care with our existing GW Medical Faculty Associates physician partners and community providers, including Whitman Walker Health, Unity Health, and Community of Hope. Based on our agreement with the GW MFA, hospital-based provider clinical FTEs will be between 160 and 170 based on actual volume through the facility. Together, Cedar Hill will provide a wide range of clinical services to all district residents, but more importantly, it will ensure residents of Wards 7 and 8 have access to outstanding care in their communities that positively impacts health outcomes throughout the Maryland, DC, and Virginia region. The 4th area of focus is community outreach. We understand the importance of engaging both our community members and leaders throughout this project. We have regular meetings with the Community Advisory Committee, and we thank them for their excellent collaboration and input. In addition to the CAC, we work regularly with the Ward 8 Health Council, ANC 7E, Anacostia Coordinating Council, Ward 7 Health Alliance, and ANC 8C. Some recent examples of our community engagement include a Marshall Heights Civic Association freestanding ED presentation on November 2nd, our participation in the Jobs Not Guns / Jobs Not Drugs citywide recruitment fair on November 14th, where we provided updates at the most recent Ward 8 Health Council And we also discussed the rollout of jobs and the need to share CBE contracting opportunities. We look forward to continuing these partnerships leading up to the opening of the new hospital and beyond. Our fifth and final area of focus is ensuring strong coordination between the closing of United Medical Center and the opening of Cedar Hill to ensure a seamless transition of care. Cedar Hill leadership and United Medical Center stakeholders meet on a bi-weekly basis to discuss priorities for transition and next steps. Our most recent meeting was on December 3rd, and we identified 4 subgroups that we'll work on. Those subgroups are patient choice, where we review the Patient Choice Act, and we develop draft documents to record patient choice of transfer hospital, incorporating length of stay and geometric length of stay. The second subgroup is transfer criteria, where we're developing draft guidelines to establish transfer criteria for patients in 3 categories for 1 to 7 days, 12 to 24 hours, and 0 to 12 hours between UMC closure and Cedar Hill opening. And the other subgroup is patient movement, where we develop draft framework and move on how to move patients from UMC to Cedar Hill using criteria identified in one of our earlier agenda items. And the fourth and final subgroup is public messaging, where we're developing a multi-pronged approach to notify the public and DC hospital CEOs of hospital closure. We're also coordinating on staffing, as you already heard. UMC has agreed through close coordination to let us know about critical positions where, although we want to hire the most qualified person and we're not going to violate any federal employment rules, we are working to see how we can manage and massage transfer employment of DC residents or employment of staff from UMC to Cedar Hill without it causing undue stress on UMC and their closure plans. Thank you all for this opportunity to share more about Cedar Hill progress and updates. I appreciate your time, and I look forward to continuing our partnership.
Thank you. Ms. Russo.
Good morning, Councilwoman Henderson, and thank you for having me here today. My name is Kimberly Russo, and I serve as the Group Vice President of the DC region and the Chief Executive Officer of the George Washington University Hospital. I serve as the representative for Universal Health Services today at this public hearing. I would like to thank you for the opportunity to speak with you today about the opening of Cedar Hill Regional Medical Center, GW Health. I also want to take this time to thank individuals who have been pivotal in the development of this important initiative. Specifically, I would like to thank Mayor Muriel Bowser and Councilmember Gray for their steadfast leadership, City Administrator Kevin Donahue, Deputy Mayor Wayne Turnage, you, Councilmember Christina Henderson, the associated support staff, and all of our partners at the district government and GW University for their commitment and partnership in this vital effort that is undoubtedly going to be transformative. Additionally, I want to thank to all involved in coordinating the efforts of today's public hearing, which is important. As you know, the residents who live east of the Anacostia River currently have limited healthcare options. This has often required them to travel across the district to seek care. As many convened here today are aware, operating a hospital east of the river has challenged the district for over 2 decades, despite the presence of many resources and many talented providers. This includes United Medical Center that has encountered significant financial and operational challenges. These challenges have left the residents of Ward 7 and 8 with a struggling acute care hospital that has seen a significant decline in patient volume, limited services, and no meaningful nexus to true integration and critical important specialty care services to comprehensively meet the healthcare needs of the residents and fulfill the gaps that we are discussing here today. At the heart of these issues is what truly matters most, our patients and the communities that we are all here to serve. I want to be clear that we are on track, as you heard from Dr. Coleman, to open Cedar Hill Regional Medical Center's doors in early 2025. This will be the first new hospital in the District of Columbia in 25 years. Cedar Hill, as you heard today, is part of an integrated delivery network of care that includes the George Washington University Hospital in Foggy Bottom, the Cedar Hill Urgent Care, GW Health in Ward 8, and the Fletcher Johnson Freestanding Emergency Department, which is scheduled to open pending SHPTA approval. This integration across our clinical facilities and community services that are currently functioning will establish a robust and comprehensive system of care for all district residents. More importantly, it will enhance much-needed healthcare access and coordination for the residents of Ward 7 and 8. These communities will now have access to a comprehensive partnered level of care that will provide high quality and care in their neighborhoods and communities. Additionally, Cedar Hill will also integrate with existing physicians, that is both the GW Medical Faculty Associates as well as community physicians. It also includes the integration of Whitman Walker Health, Unity Healthcare, and Community of Hope. UHS has worked with the GW Medical Faculty Associates, the Faculty Practice Organization, and GW School of Medicine and Health Sciences to arrange for their providers to staff the hospital and the ambulatory care center. UHS is also partnering with Children's National to bring pediatricians and specialized staff to operate the Pediatric Emergency Department, Nursery, and Neonatal Intensive Care Unit. UHS's collaboration with GW and Children's National Medical Center will provide the benefit of academic and research programming. As a result of these partnerships, as well as the community partners that testified here today, patients will have access to specialty care, clinical trials, cutting-edge treatment, and state-of-the-art technology in a coordinated, integrated, patient-centered manner. In September 2021, UHS, GW, and the GW MFA entered into a professional services agreement, memorializing the mutual agreement of the GW MFA to serve as the exclusive provider of physician services and advanced practitioners for all adult healthcare activities, provide service line and medical direction for all healthcare activities, and indicating that Cedar Hill will serve as a site for research and medical education by GW and through the School of Medicine and Health Sciences. Recently, as a result of financial challenges, the GW MFA approached UHS about revising and refining the Cedar Hill Professional Services Agreement. Notwithstanding the prior agreement was agreed to and signed by the parties because of our commitment to the success of Cedar Hill Medical Center and the important impact of the new facility will have on the residents of Ward 7 and 8, we have agreed to revise the prior professional services agreement to satisfy GW MFA's financial concerns in relation to serving the needs of the Cedar Hill Hospital and the community. An MOU setting forth the terms of this agreement has been circulated and is awaiting execution. I want to be clear that we are proceeding with our hiring as well as our provider complement agreement. The development of such partnerships to support the new hospital will be critical to the mission of Cedar Hill and enhance the medical care treatment of the residents of the community. Leveraging the capabilities of our wide range of specialists and the hospitals within our integrated system will ensure better outcomes as we coordinate care with FQHCs and many other resources in the community. Cedar Hill will consist of a trauma center, adult and pediatric emergency departments, maternal health and delivery, a neonatal intensive care unit, outpatient dialysis, cardiac rehab, infusion, outpatient surgery, clinics, a full suite of diagnostic imaging offerings, physician offices for outpatient clinics, and a helipad for emergency transports, as well as a 500-car garage to support our community. Cedar Hill will also include a dedicated 16-bed voluntary and involuntarily behavioral health unit staffed by providers who bring vast experience in serving patients throughout the DMV, specifically in Ward 7 and 8. We know that a high percentage of the patients we will care for at Cedar Hill will represent with extreme acuity and are seeking medical treatment, possibly for the first time. We also know that the life expectancy for Ward 7 and 8 is approximately 17 years less than all other wards. Based on this knowledge, we believe it is our responsibility is not only to provide excellent patient-centered care, but to also provide proactive education and coordination of resources to at-risk populations in partnership with our community providers. Preventative medicine will also be a critical component in positively impacting health behaviors. Cedar Hill is just one example. It's indicated earlier today, it is a hospital. It is not the only solution. It is not the silver bullet. We know we need to enhance the continuum of our care for our patients through care coordination. Throughout every step of the patient's journey, our interdisciplinary teams will be working together to coordinate that care along with our community resources. It's got to be clear that this doesn't stop once the patient leaves the hospital. We are optimizing our processes to ensure patients have the continued care needed when discharged. Organizationally, we are honing our strategies for greater information sharing and connection between teams. Similarly, we are closely partnering with UMC to coordinate care and address every aspect of the transition with the priority always on patient-centered clinical care. This includes our reoccurring meetings with UMC and the creation of subgroups and corresponding deliverables for the closure coordination framework. This will ensure we stay aligned in the following areas of patient choice, transfer criteria, patient movement, and public messaging. We commend the leadership and the staff at UMC who are committed to remaining open and providing high-quality care until Cedar Hill is completed. We also fully recognize the work and care that UMC staff have provided and continue to provide to the district residents during this transition. Along with our partners, including the DC government, GW Hospital, and the affiliation with GW Medical Faculty Associates and the School of Health and Medicine, UHS continues to be committed to improving healthcare in Washington, D.C. Together, we will provide full service, acute care, as well as outpatient care, as well as a robust network of ambulatory services that will be highly coordinated. Additionally, we will extend our partnership with Children's National Medical Center to ensure that we're delivering high-quality pediatric emergency as well as routine services. With that, I would like to thank you for your time today and look forward to your questions.
Thank you. All right, Deputy Mayor Turnage, I understand you have some slides. Okay, you got it. Just turn your mic on.
Good morning, Madam Chair. I am pleased to briefly report, very briefly, on DHCF's responsibilities to assist with the opening of Cedar Hill. This project is unquestioned the most important project that I have been associated with in more than 40 years of employment. I believe the hospital will be transformative for the community. And if you recall, when we began this journey with the council, we had four really clear objectives for this whole process. And that on slide 2, those objectives are identified. We wanted to ensure that Ward 7 and 8 had access to high quality inpatient care and physicians. We wanted that care to be delivered in modern facilities, and most importantly, that are connected to a comprehensive system of care. With the exception of the care that was regularly provided, none of those other factors existed. The building has reached obsolescence. There was no real nexus to the community for a number of reasons, not just the unavailability of some service lines. There were other reasons that people did not show up. We did a study once to look at how many of the Medicaid dollars that we spent at UMC was spent on beneficiaries in Ward 7 and 8 were actually spent in Ward 8. And, we spent $600 million at the time, and about 15% was staying in Ward 8. We wanted to secure a partner with a branded high-quality name and strong support and money, which is very important. And we've done that. UHS has been outstanding in their work. They've put up $75 million for the right to run a hospital that its previous model was losing money every year. We were very fortunate that they would do that. And they have been extending services since they made that decision. It will be very helpful to the operation of the system as a part of a comprehensive system of care. And we also wanted to establish a responsible end to UMC operations. And I can tell you that if you look at hospital closures across the country, they are generally rife with controversy and lots of noise. And thanks to the expert stewardship of Angel Jacobs, who is the board chair, we've not had that. It's been a very organized process. Now, there have been some noise from some corners, but I think if you look at the process on balance, she has done a remarkable job with what is a very controversial subject. And the last thing we wanted to do is remove the district from the hospital operations business. And we have done that. There's a 46-page operations agreement that governs the way that the hospital will be operated. And DHCF is not mentioned in an agreement except maybe to set rates. And so other than that, we are out of the way. And I am very pleased with that. If you go to the next slide, this gives you a quick view of DHCF's very limited responsibilities with respect to the new hospital, the closure of UMC and the opening of Cedar Hill. We certainly will have to ensure as the insurance agent for Medicaid and Alliance members that they are transferred to the hospital of their choice. We cannot dictate that choice to them. We mentioned prior authorizations, but we haven't done those since the end of the public health emergency. We stopped them during COVID, and we haven't done any since then. And My staff telling me this morning that we have not restarted prior authorization. So there will be no prior authorization process to govern the transfer of patients. We will also, with closure, continue to process UMC's their claims. And then we'll close out their work on the capital fund. Those capital fund dollars sort of flow through DHCF. They have to submit a plan for use, then it has to be approved. And so that process will be closed out. On the Cedar Hill side, they are in the process of securing a Medicaid provider agreement, which they must have to operate. And that process is well underway. It will certainly be done in time for the opening of the new hospital. We do set the annual reimbursement rates for Cedar Hill as we do for all hospitals, and there's a little bit of a, not a challenge, but a little bit of a difference. We have a contract that specifies how we should set rates at Cedar Hill that was negotiated back in 2021. But we do regular reimbursements for all the hospitals, and we have to make sure that whatever we do for all the hospitals does not sort of contradict or conflict with what we're doing for what we are contractually required to do on the Cedar Hill side. And that process is well on the way. Angelique has met with both Kim and Tony to discuss, any kind of changes that need to be made to the proposal that we initially put forth, and there will not be any problems there. There's a lot of coordination with the workforce training program that Ben Stutz, who's at the table, oversees in working with Cedar Hill and UMC. We also are going to work with them on targeted marketing agreements, hopefully make the community aware of this wonderful new facility that they will have the benefit of using. And we will assist Cedar Hill in any way they ask with respect to job fairs and associated direct marketing. I did for your benefit listed all the other agencies on the last slide that are involved in some way or fashion with the opening of Cedar Hill. This slide identifies those agencies, provides a description of what they're doing, and provides a status. Everything is, nothing is code red. And if something does hit code red, we hear about it pretty quickly. So with that, I will close my comments.
Thank you. Thank you all for being here and for your testimony today. I would just say for the record, we did invite GWMFA to testify. I think there was some scheduling mishaps with Mr. Elliott, so he wasn't able to be here, but I'll just say that from the offset. Okay. All right. I have some questions that I want to get through, and I'm kind of go out of order here because Ms. Russo, in your testimony, you shared some news, sort of. Maybe not news to you, but news to us around GWMFA wanting to revise the professional services agreement from 2021. You have always been very calm. So tell me why we shouldn't freak out about this.
Well, ultimately, it's UHS's responsibility to have physicians to staff the hospital. And I have no issue or concern with our engagement and collaboration with the GWMFA. This is truly to shore up any financial potential losses that they may have.
Okay.
And UHS is committed to doing that. It does not change their commitment. It does not change our collaboration. And we are full force ahead in our clinical FTE provider complement agreement and who we need to hire in order to open the hospital. So I have no concern on that.
Okay. Okay. So we'll come back to that, but let me ask about the other partner here. In terms of your agreement with Children's National, is that solid as well?
It's in its last implementation phases.
Okay.
It's with the legal people doing, the formal contracting, but we meet with them almost weekly, right, Tony? It's every Friday, every Friday. So it's moving, rapidly. And it's also in coordination. As you know, they also have the emergency services at UMC. So we're working through that transition with them as well.
Okay, great. So I want to step back because I feel like in a lot of our conversations about Cedar Hill leading up to sort of this moment, we've been talking about the construction piece of things. And I actually want to focus a lot more on what's going to happen in terms of the internal workings of the hospital. So it's great that the construction, 85% were there and we're moving ahead. I think we have a tour in January. So we look forward to seeing it with walls, because I think the last time I was there, there were no walls. And so that's great. So I want to go back to talking a little bit about the clinical services piece of it. We had some of the FQHCs and community providers testify here. There seems to be, or I'm not entirely sure. It seems to me sort of a chicken and egg type of conversation. I have a lot of providers who are trying to figure out what is going to be the credentialing requirements or the credentialing agreement standards. But it seems as though GWMFA needs to, I guess, put on paper what those clinical standards are for credentialing standards, and then you all are able to share that outwardly. Is that how this goes, or are they just going to use the same agreement that they already have with
So
the hospital?
just for some clarity, the GWMFA does not do the credentialing for the hospital.
Okay.
So just for clarity from a governing process, the credentialing bylaws have been crafted. And our agreement is that the GW Medical Faculty Associates and their physician leaderships will approve that credentialing process that has been provided and approved. The credentialing process is also mandated per our agreement with the District of Columbia to mimic almost exactly GW hospitals, so that there is the similar level of care and expectation in terms of the qualification of the providers.
Great.
We are in the process of appointing our board members. The board has to approve those credentialing because the board of the hospital is really responsible for three things. They're responsible for credentialing, they're responsible for regulatory and accreditation approvals, and they're responsible for the quality and patient safety that occurs within the hospital license space. So our board is just now getting ratified. And then we will have them do a special meeting, probably early January, to approve those credentials. And I'll let Dr. Coleman engage in a little bit more. He's more on the logistics side, but he's working with representatives at the university and the MFA to kind of have some community outreach and opportunities to express what those credentialing requirements are.
Yeah, no, this is more information than we've had in a while. And I think that this provides some excellent clarification around the steps and process.
Yeah, and it's again, it's a moving, and it's a moving process. And obviously we aren't going to do credentialing, a year out. It's like there's obviously staged phased processes that we know we have to do as we ramp up to open a hospital. But Tony, do you have anything to add?
No, you're spot on, boss. So the best way to think about it is if you take it from the beginning or from the end to the beginning, from having a physician credentials, physicians can't be credentialed unless the medical executive committee bylaws are intact. Medical executive committee bylaws can't be intact unless the governing board approves it. The governing board can't approve it until that governing board is appointed. Per the PSA that you have in front of you, our governing board will have 11 members. 6 will be appointed by UHS, 3 will be appointed by the mayor, and 2 will be appointed by MFA. We just got the majority of those members about 2 weeks ago, and they were appointed at the beginning of December. So to Kim's point, our inaugural governing board meeting will be in January. Well, they will do 2 things. They'll approve the governing board bylaws for the hospital, and they'll approve the medical executive committee bylaws, which will create the pathway to credentialing physicians.
Okay. Where will people be able to see at least who the 3 individuals that the mayor named?
I'm sorry. My bad.
Come here with us.
What was the question?
When or where will individuals be able to know who the 3 individuals that the mayor named?
The names have been submitted to Steve Walker, who sort of manages the board appointment process. Then he vets the candidates, gets them before the mayor, and the mayor makes a decision. I assume that would be happening in the very near future. I don't want to put a precise date on it, but they have the names for the recommended names for her candidates. And so that decision should be made soon.
Okay. All right. Okay. So hopefully this was helpful for providers who might be listening in terms of what the process is and the timeline things there. Okay. We talked about that from the clinical side. Have you all made a final determination on the specialty items that are you going to or specialty service lines that will be available on the campus?
We have, and I'll let Tony expand a little bit on that. Our commitment is to meet the expectations of the certificate of need, which outlines those clinical services that we are expected to have, with the understanding we would also need to notify the district government 180 days prior to change of any of those services. We're not expecting to change any of those services.
Okay.
So I'll let you go ahead and speak specifically to those specialty care services that we will be opening with.
Absolutely. So when I think about the services that we're providing, the best way to remember it is you have hospital-based services and non-hospital-based services. The non-hospital-based services that will take place in the ambulatory pavilion, which is the clinic, are the ones that I'm going to speak about. So we have a family medicine clinic, general medicine clinic, cardiology, pulmonology, nephrology, oncology, hematology, neurology, endocrinology, GI, rheumatology, infectious disease, palliative care, geriatrics, dermatology, ENT clinic, urology clinic, gynecology clinic, and obstetrics clinic. Now, when I mentioned those clinics, but the way that they're going to operate in that limited clinic space is on what's called a timeshare model. So all those clinics won't be there 5 days a week, right? But it's based on the need. And so I've been talking with the MFA about their expected number of patients that they're going to see, and that'll drive the number of days that the clinic will be open or hours per day. So all of that is still in flux based on the patients that they expect to see. But those are the services that were listed in the PSA that we've been negotiating.
How many patients do you all anticipate seeing in year one that are not coming through the ED?
So I think I don't have that exact number because that's an estimate and it's based on clinics, which I think the MFA will be better suited to answer.
Hence why we invited them to join us today. So I'll give you an example, something that we were talking about kind of earlier around on the maternal health piece, which is, I hope you're hearing from the testimony, this is going to be a crucial piece for the community because there have not been able to be births not in an emergency room happening east of the Anacostia for a number of years. And so I would, the sort of questioner in me would wonder, how many patients currently does GAW MFA have who have zip codes that are in some of these areas? Because again, we don't want it to be a situation where the only births that are happening there are those that are coming from an emergency, or this is the first time that Cedar Hill is, or the physicians at Cedar Hill are seeing this patient at all, right? I think we have that happens at some other hospitals where that is certainly a challenge. So how do we build that relationship? And I think part of that is around who is GWMFA already serving, and is it a possibility that they're able to now provide care closer to where they live? I don't know if those conversations or analyses are sort of happening. That's all. Yeah.
Yes, those conversations have been happening. You touched on something that if there's anything that keeps me up at night, it's the question of volume. What's the volume going to be? And just very briefly, as I think about that, there are about 3 different elements that I think about when I talk about maybe estimating the volume. You have the first element, which are the amount of patients that currently go to United Medical Center. One can reasonably assume that the majority or a good amount of those patients will come to Cedar Hill. We don't know, but one can assume based on, we'll say, proximity or geography. The second factor is there are patients that live in Ward 7 and 8 that travel across the river to seek care at other facilities that it's reasonable to assume they will now say, oh, there is a new hospital in Ward 7 and 8, I don't have to go across the river. That's another element of volume that we are estimating. And then the third element is the amount of people that live in Ward 7 and 8 that are home now that because of the historic lack of trust that that community has with the medical establishment. There are people that sit home in Ward 7 and 8 and say, I'm just not going to go to the hospital. I'm going to wait till that shiny new hospital opens and I'll go. There's no way to estimate how many of those people are either. So when you think about those three groups of people, that is what's going to encompass the volume that we're going to see. And that's an answer that I just don't have.
Yeah, either one other group that you're missing are the group of us that are just nosy, right? I don't actually have a need to go to the hospital, but it's new and I want to see. And they're going to try to kick the tires to see, am I going to get a good experience when I go? So now it's a word of mouth type of deal. So I don't know. I think we put money in the budget for opening, marketing. Then yes, something to that effect.
But I wanted to clarify one
Yeah,
point.
yeah.
It's very important. Is the one difference that I want to make sure the community is aware is if an individual comes into the hospital, comes into Cedar Hill, and they are delivering a baby, they will not deliver in the emergency room unless it is that critically close, just like we do at other hospitals that have an OB department. We make sure that they are up in the obstetrics ward. That's going to be what is different than if delivering right now at UMC, since they don't have the obstetrics.
Right.
So I just wanted to clarify that.
Oh, yeah.
Absolutely. I think sometimes I take for granted that every hospital that I've worked in, we've had OB. So yes, absolutely.
Yes.
Oh, yeah.
I think
yeah.
it's very important.
Oh, okay. Yes, I'm clear on that. So yes, let everybody be clear on
I
that
don't want
front.
people thinking if they come to Cedar Hill and they're pregnant, they're going to deliver in the emergency room. That's not how we're going to deliver.
No. Okay, so we've talked a little bit about construction. There's obviously some regulatory things that need to happen. Deputy Mayor, you had the slide at the end of your presentation that talked about all the various agencies. I imagine that there's some ongoing communication, particularly with our good friends over at DLCP and DOB and Fire and EMS, to make sure that the permitting sign-off pieces are not delayed. I'm hoping that this hospital is receiving the white glove treatment.
Oh, I don't think there's any question that it is. Ben Stutz, in addition to sort of working as the chief operating officer for GHCF, has the primary responsibility of providing, making sure that there's a nexus between all of the agencies that are involved in connecting them to UMC. I mean, to Cedar Hill. And if there's a problem, then he is supposed to let me know immediately, and he does, and we address it post haste. So Ben, if you want to add anything to your efforts, feel free.
Thank you, Deputy Mayor. Only to say, Chairman, that the agencies that you saw on that list, nearly all of them, either the director or their senior staff, have been out at the site, and/or we have had multiple meetings with them in the prior months and in the coming months. So every agency is aware. Every agency has had a chance to put eyes on the site. And obviously, UHS and Dr. Coleman are providing all of the content that is required for the regulatory approvals.
Okay. Let's talk now a little bit about communications and whatever that communications plan is going to look like. It's one thing to have individual conversations with providers or to attend, say, the Ward 8 Health Council and otherwise, but for communities in that area of the city, we do need to be a bit more intentional around, number one, when we have a date saying like, this is the date. And two, here are all the available services that will be offered that can have that. Have we hired someone for this type of plan? Is this a January, February project? Talk to us a little bit about the communications plans.
So we have a communications individual now that I work with that's helping with communication. So in terms of a robust plan that I can give you now, I don't have that. But we do, as we mentioned earlier, I do attend regular meetings with the health councils and some of the ANCs to not only to give information, but also to listen to questions and take that information back and create that open dialogue.
I would just add, UHS has significant experience in opening new hospitals. And so not that we're going to pull something off the shelf and say it's going to fit here, but we do have a templated comms plan for opening new hospitals that will start with a 30, 60, 90 day once the date is secured. And those comms plans obviously would be in coordination with Deputy Mayor Turnage and the mayor's office accordingly, because it is important to notify the public of the date, but also of the services, and making sure that we're holding informational sessions, et cetera. And I know that there will also be some opening for the community to kind of understand and kind of feel the hospital and have an opportunity to ask questions.
Great. Oh man, the question I was going to ask you has just flown out of the window, and hopefully that it comes back to me on that front. It was important too, but it's going to come back. Okay. Let's talk a little bit about the Cedar Hill relationship or not, or what, if you all can speak to the Cedar Hill Alliance for Health Equity and what has been happening there.
Yeah, I can speak to that. After I received your letter, I did some research that the Cedar Hill Alliance for Health Equity was launched by GWMFA in June of 2023. There were 2 meetings. The last meeting, I think, was later in that year. I've had conversations with MFA about how we may integrate into that alliance, but beyond conversations, I don't have any information about it.
I would just add that that's really from the Center of Population Health Sciences through the School of Medicine that has participation of the GWMFA providers. That's more on the GW side, which if you look at the agreement, not only within the district and UHS agreement, but also within our professional services agreement with the university and the faculty, we have committed funds for population health sciences and research. So this Alliance on Health Equity is really a conduit to really start that work. There was some confusion because we also have to have a community advisory council for Cedar Hill per agreement.
Yeah.
So that, is going to start taking over some of the responsibilities of the CAC once we, open, that will really start that population health science and discovery in terms of doing the work that we are contractually obligated to do in terms of transforming.
So the
health.
community advisory committee or council will still happen.
It will happen on a much lesser frequency, with a lot of the population health occurring once we open the hospital.
Okay. Right. You mentioned, Dr. Coleman, that you all have hired some of the executives or some of the leadership per se. Have they started, or, and I'm asking that because I don't need to know who the people are, but I'm just kind of wondering what the positions are, because it might be easier on your inbox if you can start to delegate some of these meetings and responsibilities. So like if you do have someone who, I don't know, is COO operations outreach type person, that's now the person that folks should be connecting with to ask some of these additional questions, as opposed to just coming to you or to Ms. Russo.
Yeah, no, that's a great question. So to date, we've hired our COO, Vaughn Williams. We've hired our CNO, Tony Reyes. She started about 3 months ago. We've hired our director of supply chain, our director of facilities. We have extended offers to a director of emergency and critical care. And so to your point, the care coordination work, I've asked my CNO, Tony, to kind of head that up. I'm still involved, but she's kind of taking the lead, liaising with the district on construction and regulatory approval. I've asked Vaughn, my COO, to head that up, and I'm still heading up community-facing communications and kind of overseeing everything else. We do have a number of individuals starting on Monday. And we have some key leadership positions that are scheduled to start on the 30th of this month as well.
Okay. Is there on the website somewhere where we would know what you're hiring for now?
I haven't looked at the website, but I could, is it up? Okay. Yeah, it's up.
On the Cedar Hill site. Okay, great. So folks who might be watching and interested to see like where they can figure out information, they'll be able to do that there. Okay, let me ask a couple of questions, healthcare finance around the UMC closure piece. So you mentioned in one of your slides that healthcare finance responsibilities include sending all prior authorizations to the new hospital, a standard process for all Medicaid providers. What type of prior authorizations does this include, and how can you say a little bit more about healthcare finance facilitating transfer? Oh, sorry. Yeah.
We haven't done any prior authorization since the pandemic.
Okay.
What we do now is we get a list from all the patients where Medicaid is their carrier, and then we monitor the transfer process. Then there's a group of patients called long stays. They don't really have any acute care needs. They're just into the hospital because they have nowhere else to go. So Melissa Bird, our Medicaid director, works specifically on trying to find long-term care placements for those persons, because Cedar Hill will not accept people who are using UMC for long-term care when they don't have acute care needs. So we have to make sure that those persons have somewhere to go, and we work every day on that.
Okay. I'll just offer, as I said earlier, I don't think you were in the room at the time, but I'm sure some of our other hospitals would love that type of help.
Yeah, and we've done that with MedStar. I think we've done it with GW as well. Melissa does a very good job with that, because that's a very difficult thing to do, particularly when you are talking about persons who have no connection to any health insurance at all, and trying to find a place for them to stay long-term when there's no long-term care payer is a very difficult thing.
Yeah. So what's the executive's plan for maintaining the property where UMC is currently located after its closure?
You mean UMC?
Yes.
That plan is still being developed. I think there are a lot of things being bandied about how that property should be best used. Should it be used for another healthcare type facility like mental health? Should it be submitted for redevelopment? I don't know, those decisions haven't been made. Once they are, of course, you will be one of the first to know.
Okay. I'm actually not necessarily speaking specifically around its next best use, but how do we ensure that while the property is vacant, it's not being vandalized, broken into, X, Y, or Z?
The city will ensure that the appropriate, and maybe Angel or Eric can speak to this better than I can, they will ensure that the appropriate personnel are there to keep the facility from becoming a hellscape.
Okay. In terms of the website, in addition to the hiring pieces, if someone is looking to do business with Cedar Hill, I don't know, laundry, catering, food, gift shop, all the various other pieces, are those opportunities or RFAs? I'm not entirely sure how you do it on the private sector side. That's why I'm using the government language, but how would those procurement activities go forth?
Yep. So great question. Our facility contracting officer started with the organization on December 2nd. That is one of the top of the list that I have for him for developing that. So I should have something on that pretty soon.
Okay. All right. Give me just a minute. Okay, couple of really quick questions. So it was brought up in testimony earlier by both of the FQHCs who testified around some of the good that can come out of having FQHC staff at a hospital in order to help with that care coordination work. What are your thoughts on that?
Totally agree. Care coordination and discharge planning, they're spot on.
Okay, so, and I imagine that's something that already happens at GW Hospital, maybe-ish?
We don't have, we have various members of the community, of FQHCs, even some of our subacute facilities that have intermittent engagement. But, it's always an opportunity, I think, to really look at, to the earlier testimony of how we really utilize the talent and resources that already exist to maximize those for the greater good of the community. I think we can learn from some of the patient journey and care coordination work that we're doing as a collaborative with the opening of Cedar Hill that can be offered to other health systems, including GW.
Okay. It was planned that at the Cedar Hill campus, there would be a family medicine residency. Is that still going to happen?
That is still happening.
Okay.
We are also, that doesn't happen day one.
Right.
So it is a complex process, and Dr. LaQuandra Nesbitt is leading that charge in terms of developing that family medicine process, because it is a new program.
Right.
And not only a new program for Cedar Hill, but also a new residency program for the School of Medicine and Health Sciences. So that work is well on its way. I'm not as well versed as I'm not involved. We will be funding it.
Yeah.
But obviously, definitely looking forward to that integration and the launch of that program.
But the other residency programs outside of family medicine, you all have them in a variety of different ways. Are there going to be opportunities for students to work at both locations?
So medical students, yes, there are no residency programs outside of family medicine right now.
Okay.
That takes years to get the residency slots allocated from CMS.
Yes.
We will be working with our GW School of Medicine and Health Sciences to kind of look at what makes the most sense from a residency placement perspective, and then pursuing that as the time evolves. And we look at the volume and kind of get an idea of what kind of patients are we getting at Cedar Hill that would be of a great teaching opportunity.
Okay. And then finally, I imagine that this is probably something that comes after the board has had a conversation, but I think one of the things that the providers also mentioned a desire to see is some sort of formal care coordination plan or something on paper. I know you said you have hired a CNO to have some of these conversations, but I would just offer that as something that came up today's conversation around whatever that might look like. I don't actually know what that might look like, but
yeah, I think there's a couple of things. Every hospital has to have a provision of services, which includes care coordination and is required by the Joint Commission. So there's obviously plans that will be approved by the governing board. In addition to that, obviously working on collaborative care agreements and looking at it as a multi-partner opportunity to really look at how that care coordination and collaboration can occur. We've been open to that and have worked and provided collaborative agreement terms for quite some time. And so I think that the work is well on its way, and I think it'll evolve as we continue to look and see how the care is going to be provided and what different resources exist within the community.
okay. And as we look towards opening, what's the deciding factor on the opening date? I imagine there are a number of different things, but if, who says, who is like, okay, and we're good, 100%, let's go, or yes.
It's multifactorial, as you mentioned. When I think about opening a hospital, I kind of split it into two different blocks. There's the regulatory approvals to get the facility certified from a fire and life safety perspective. And then there are the regulatory and Joint Commission and certification approvals to operate the hospital after it's open. So all of those things have to happen. Some of them happen in sequence, some of them happen in parallel. And that's not even counting construction, whether construction is happening on time, which fortunately it is. So it's multifactorial, and it's really hard to just say, this is the one factor that will determine the opening date.
Okay.
So you're asking who's going to call the shot that the hospital is now ready to be open?
Obviously, this is important for a variety of different factors, but I'm also thinking about our good folks over at UMC who have made a commitment to stay, but if that date is like a moving target that keeps moving back or otherwise, that's why I'm just trying to understand and we're ready. Because Dr. Coleman, I know this is, I think this is your first opening, your first new hospital opening. You might be like, oh, I'm not ready yet, but Ms. Russo is like, nope, and we're going. So is it the Joint Commission approval? That's what I'm just trying to understand. What is our deciding line here so that it's not, the date isn't unnecessarily sliding such that UMC can't keep operating. Does that make sense?
Yeah, no, that makes perfect sense. the opening date has been banded so far. We said, late March, mid-April, somewhere in that time period. Now, if something happens that, and Tony says, okay, we're gonna have a problem, we have to go beyond that, then we'll let people know. But right now, I think the consensus is we're shooting for a late March to mid-April opening day without, further complication.
And that's exactly right. And the reason it's banded is because we are dependent upon agencies to give us approval.
Yeah.
And so I'm not going to authorize Tony to say we're ready to go if we don't have our CAP inspection done so that we can run labs and our diagnostic imaging equipment certified for safe operations. I mean, there's a multitude of approvals and regulatory agencies as well as accrediting bodies that will need to come through the hospital to say you are safe to operate.
Right.
And that's our commitment, is when we say we're ready, we are ready. And that's really dependent upon those agencies and the timing associated with that.
Okay.
We're backing into that date. That's why it's banded,
Yeah.
but we've got to have some room.
Right.
And they're local and federal agencies, so it's multifactorial.
Oh, I know that part.
Yeah.
CMS says otherwise. I just, I think that, whenever there is a date, then it becomes more real in the same way as when people are able to walk in, it feels more real. As sort of right now, it's a building that is under construction, and sort of, I think for some people, especially in the community, because they have been hearing about this hospital for so long, we are talking about, for them, it's just a concept. It's not real yet. And so when we can get there and start having those word of mouth conversations, because as you all know, a lot of decisions in healthcare, who your physician is, where you go to seek care, services, et cetera, it's based on you've asked a friend or 10 friends or their parents or otherwise, hey, what happened here? Hey, I have this going on. Or, I'm on a group chat where people are often, hey, do you have a pediatrician that you like? Like, that's how it happens. It's not the websites, it's not the other things, it's really around who you know. And so what happens in that first year and a half at that hospital is going to build the reputation of how people feel about it going forward. So we just wanted to make sure we're on that track. Okay, I don't have any further questions. Is there anything you all want to say that I haven't asked?
Not me.
Awesome. Okay. If you all can submit the written testimony that you provided today so we can have it for the record. I look forward to staying in communication with you all in January as the board comes on and some of these things sort of fall into place. I imagine that sometimes it's slow at first, but then it starts to happen sort of a rapid drinking from the water fountain fashion. Ms. Russo, whenever you all have the final agreements with GWMFA and with Children's, we'd love to know that those have been signed and executed. And I want to thank everyone else who testified today and contributed to today's roundtable. Again, this was around let's just have a conversation in public, because I feel like a lot of conversations have been happening at community meetings, but people not knowing what's going to happen. And I didn't want us to get to March and that be the first time that we talk about some of the actual services that are happening therein. So I encourage the rest of our district agencies who are responsible here to continue to collaborate with each other and with the council to address any issues that might arise as we hit these milestones and critical transition points. It's imperative that we prioritize the needs of the community, ensuring continuity of care and minimizing disruptions as much as we possibly can. And with that, there's no further business before the committee. For the rest of this year, for the rest of this council period. It's our last hearing. And the time is 11:48 and this roundtable is adjourned. Thank you all so much.
Thank you.